Hello, I'm Graham Newstead. I'm a colorectal surgeon, and for purposes of this presentation, I'm Medical Director on the board of Bowel Cancer Australia. And I say that because we've spent a lot of time dealing with the federal particularly, but also state governments in recent times, and especially since the introduction of new items for colonoscopy from November 1 of last year, 2019. And when I say new items, I mean these are items as written in the medical benefits schedule for our use of federal funds provided by Medicare. And it's now, golly, nearly 50 years since colonoscopy commenced. The instruments were invented in '69. It was '71 I saw my first instrument, and they were pretty difficult years because we were looking in colons with very poor equipment, and it was like chasing a black cat in a dark night. And now the equipment is wonderful, and it's been used increasingly to enormous benefit and to some extent abused, and it's the consideration of abuse that is used too frequently by the federal government because of the amount of money that's being expended, and I will come back to this, that they decided it was time to actually review the item descriptors that we colorectal surgeons and gastroenterologists can use, hopefully to the benefit of our patients. And there are some good things to tell you, and there are some worrying things to tell you, and we thought it would be helpful for general practitioners to be updated on both aspects of the picture. So we're going to try and do that now for you. And previously, a patient who had symptoms pretty much would always, in the recent 20 or 30 years, get a colonoscopy. And that was so for the maintenance of ulcerative colitis overview, particularly after a number of years of significant and persistent disease. Certainly if you had a family history of bowel cancer, and especially a first-degree family history of bowel cancer, and I'm generalising my practice, but I think it was in keeping with most other practitioners of reasonable behaviour, 4 yearly, and that first 4 yearly colonoscopy would have been expected to occur about 10 years younger than the proband, that is, the first-degree family member had his or her bowel cancer. A strong family history, of course, would be of more concern, so we usually did them at 3 years, or previous polyps. Now, the previous polyps were a worry to the government because we would lump, I'm being generic here, would lump most patients who had a polyp removed into the 3 yearly group, and there's a huge variation between a big concerning polyp and or a number of important polyps versus a tiny hyperplastic polyp that's unlikely to cause any trouble. Past resection of bowel cancer, 2 years, because we were concerned about the risk of further polyps and the risk of those polyps turning into a cancer. And finally, average risk. What did you do? Well, for a number of years now, we've had a 5 yearly bowel cancer, national bowel cancer prevention scenario, where the federal government would wonderfully offer a fecal occult blood test kit, now called the IFOBT or FIT, to indicate the immunochemical materials that are used, so that the pickup rate, the accuracy rate, was much improved. And so for average risk, or that tiny hyperplastic polyp patient I mentioned, it's say about 5 years. This was based on the understanding that it probably takes, on average, about 5 years for a polyp that's going to become a cancer to become a cancer. Now, it's important to realise that the vast majority of polyps, 40% of males in Australia get polyps and 30% of females, will not become cancer. It's only a minority of polyps that go on to become cancer. And if we see a big aggressive polyp, we have some understanding that this is clearly en route to becoming a cancer. But if you see a tiny 3mm polyp, we have no idea whether that polyp is at risk of becoming a cancer or not. So we remove them. And therefore, because we don't know that that patient might or might not have developed a cancer in the future from that polyp, we repeated the colonoscopy, and that was the 5-yearly previous adenoma group, or for the tiny ones or an average risk person, 50 and onwards, 5-yearly. Now, FOBT was always done if the National Bowel Cancer Screening Program, IFOBT, was positive, because we could assume, often incorrectly, that the bleeding was coming from something proximal to hemorrhoids. Indeed, 85% of polyps less than a centimetre have a less than 1% chance of cancer. And they are going to be negative, which basically means we miss 85% of small polyps. Does that matter? Well, probably not, because of what I said a moment ago. Most small polyps don't turn to cancer, so it probably doesn't matter. How are we at picking up a bigger polyp of 2 centimetres, double the size? Not very big. A polyp of 2 centimetres actually has a 40% risk of bowel cancer. The good news is that rather than missing 85%, as with the little polyps, it finds 70% of them. But it therefore misses 30%. And if those 30% have a 40% risk of bowel cancer in them, that means 30% are false negatives, which is, for my simple mathematical mind, a 12% or 1 in 8 cancer miss rate. So it ain't perfect. It's a very, very good thing to have, and so much better, as we've noted here, than doing nothing. But it is an imperfect exercise. The other thing that's bad about the National Bowel Cancer Screening Program is that we've got the figures up for participation from everybody who is on the Medicare register from 50 to 74 to actually do the test and return it. We've got them up from 37+% to, wow, 40%. There are still 60% of Australians who are not doing them. Now, there are more women that do them than men, and I would maintain without any evidence that this is because women are the nurturers and they get their mammograms done more comfortably. They get their gynecological pap smear done more comfortably. And the guys don't need it because I'm all right, Jack, and I'm going to be fine, and I don't get these things. So anyway, we clearly need to improve the uptake and the return of the bowel cancer test kits, because they are so much better, as we've said already, than doing nothing. And the mortality has been shown. We've been doing the FITs long enough to know that the mortality is reduced because of stage shifting. That is, when they are positive, the tests, due to a large polyp or an early cancer, and the patients have early surgery, we are actually changing the mortality rate by moving the stage of the cancer that's identified and removed from advanced to much earlier, and thereby curing. So that's important. Just for fun, a number of years ago, we looked at the cost of doing colonoscopies for every member of the Australian population, 50 and over, every 5 years as an exercise. And we took all the patients, the 15,000 just under, who are getting bowel cancer, and they're all different stages. We know the percentages in the groups, and we know what we do to those people in those groups for their follow-up management, be it cure or be it late-stage disease with chemotherapy and radiotherapy. And when you applied the cost to caring for those 15,000 people, it was almost the same as offering colonoscopies to every member of the Australian population, as I said. So it's a question of whether we're into prevention or case finding and treatment. And clearly, all of you watching would agree that prevention, as far as is possible, is good. And for men who don't smoke, you watch their skin, and basically then the common cancers are prostate and colon. For women, you've got to chuck in, of course, instead of prostate, breast first, but then maybe add ovary, maybe add pap smear, of course, and then maybe add ovary. And even though the Ovarian Cancer Foundation don't push ultrasound of the ovary, it's something to think about for your patients. The wonderful news, and this is really good, that with pushing from many groups involved in this with federal government, including particularly Bowel Cancer Australia, as from this month, we're recording this for you in January of 2020, the National Bowel Cancer Screening Program, FOBT, will be sent out to every adult member on a Medicare register 2 yearly, not 5 yearly. I think it was about $14 million extra put into this exercise, and it's fabulous because if you had a false negative from an FIT that wasn't bleeding the day you did your test and you waited 5 years, it might have been for a cancer. Now you'll have another FIT 2 years later and pick up that polyp which wasn't bleeding then but might be bleeding now, or at worst is an early, hopefully curable cancer. And therefore, not only is it good news that we'll get this second yearly, but the big push that we need to do, especially through general practitioners, is to encourage people to complete and to return their FIT. There is a problem here. The funding for screening is federal. The funding for colonoscopies, and I'm sure we will see more colonoscopies because of the more FITs being done and more positive results being encountered, will require state funding. And we've spoken to the federal people about this, and they have said, it's a problem because the states will want more money from us. So we still have to address that, and I promise you we will be. It's not so much a worry if you're privately insured. It's a big worry if you're public and you're in the public system, because the waiting list at the moment for colonoscopy in most, not all, and there's a range, most teaching hospitals is well over the recommended 30-day interval to prevent stage shifting of your cancer, having been positive, FIT from cancer, and you need a colonoscopy. And if you wait more than 120 days, there is good evidence to show a stage shift and therefore a much lower risk of being cured from the surgery for that cancer. Now, most of the public hospitals are between the 30 and the 120. And if we can get it to back down to closer to, if not 30 days, then we'll be saving more patients' lives. Why the changes then in the item numbers? In 2018 to 2019, there were over 300,000 colonoscopies performed, and 310,000 colonoscopies with polypectomies. A lot of polyps, and the feds would say a lot of them being removed unnecessarily. There was a 26.4% increase in colonoscopies between 08 and 18 in a decade, a 26% increase in colonoscopies and a 140% increase in polypectomies. Were there more polyps? No, more colonoscopies being done and more polyps being identified. Well, I'd have to ask as a devil's advocate, is that bad? Well, first of all, we're aging, and we are aging in a healthy manner. The average age of death in the United Kingdom at the turn of the previous century, 1890s to 2000s, to 1900s, was 50. The average age is now in the 80s. So we are living longer and healthy, but we're living long enough to get polyps. And we have a national bowel cancer screening program picking up positives. We need colonoscopies. And yeah, we live in the country with the best care in the world. I look after this internationally. We do a lot of outreach, training and promotion of bowel cancer prevention programs through the International Council of my specialty in over 52 countries. And there we have the best care in the world. It ain't perfect. Does that mean we should give less? I don't think so. We do have a very definite reduction in mortality, not in incidence. And indeed, we are seeing younger people with bowel cancer. 10% of the bowel cancers occurring in Australia are now occurring in people under 50. When I was a med student, nobody got bowel cancer under 50 unless you had familial adenomatous polyposis. 10% of them are occurring in people under 50 without a first degree or any family history of bowel cancer. And that's mirrored by America, where 15% of their bowel cancer are occurring in people under 50. And it is highly likely that this is due to the foods we eat, but we have no absolute evidence for this. If we eat different foods, meat which has contained antibiotics to stop the animal getting bloat when it was fed in a feedlot, pesticides, preservatives, additives, all this stuff, not naming one specific item, but all these things our bowels probably don't like, our bacteria probably like even less, and therefore there's a problem. So I say crikey on that slide because we have to find a balance between maintaining and indeed improving ourselves as best care in the world, but at the same time not throwing out the baby with the bathwater, because we've got to a stage over 50 years with bowel cancer prevention, which is wonderful, but we also don't want to lose the benefits of that because there are costs involved, without ignoring the fact that all this stuff costs money. So here are the new items for you upon which to cogitate. They're self-evident, I won't use the pointer, you can read them. But item 3(2) is a patient with symptoms, and the working party that gave the information to the government has said if you get a positive blood test, Figaloco blood test, of course you will be having a colonoscopy. Anybody with symptoms that concern you as a GP or me as a colorectal surgeon or our relevant colleagues, anybody who has symptoms gets a colonoscopy, and this is all, by the way, covered by Medicare. This is purely the discussion in this presentation, because otherwise Medicare won't cover it. In the public hospital, the waiting list will go sky high, or the patient will have to pay the whole thing out of his or her pocket because they won't be covered by their fund as well. Because if Medicare doesn't cover it, the fund won't cover it. So it's thousands of dollars out of pocket to have themselves assessed, or a long waiting list in the public system to be assessed, and we mustn't allow this. Anybody who's anemic or iron deficiency, anybody who's had an X-ray of some sort or a CT scan which suggests pathology in the bowel, anybody who's having their first colonoscopy after colectomy for bowel cancer, of course, is covered, and anybody who had a bad bowel prep and it didn't work but had a good indication as above for a colonoscopy, they will get a funded colonoscopy. Or for the management of inflammatory bowel disease, chronic ulcerative colitis, where you have concerns about dysplasia. And interesting, they allow once a day, which seems to me weird because that's a rare thing that's going to happen, but at least they can be dealt with. So that's a no-brainer and important, and the majority of our patients will fit this category. The next one, they're all simple, they're all 3, 222, and a number, and they go from 2 to 9. And this is a patient that had, this is looking at the polyps now, previously had 1 to 4 adenomas, all of which were small, and had none of the concerning features like a villus pattern, they usually have a tubular pattern, and did not have high-grade dysplasia indicating a propensity for likely cancer, or had a family history of bowel cancer, who had a previous colorectal cancer, and the first colonoscopy did not show any polyps after their resection. Now these all get a 5-yearly review, and here I have a concern, because if you look to the right of the slide, the concern is the family history group, that is B on that item. A patient may be considered at moderate risk if the family history was as follows, and this is really of great concern. 1 first-degree family member less than 55 years of age at diagnosis, or 2 first-degree members, or 1 first-degree family member and 2 second-degree family members at any age. And I'm going to come back to this later to talk to you about it, but historically there is plenty of information that in the literature that would suggest the risk of a colorectal cancer was twice the normal risk. That's 1 in 22 for women and 1 in 18 for men. And it's twice the normal risk. That's high, and yet no colonoscopy is recommended for a first-degree family history of bowel cancer if Dad was 56, let alone, or 85, of course. Now, let's move on to the next one, and we'll come back to that. And the 4 item, 32224, is a larger polyp, 10 millimetres, or had concerning pathological features, or when it was an advanced sessile serrated adenoma, right colon, Lynch syndrome. Those occur. They also occur without Lynch syndrome or hereditary non-polyposis coli, and they are more premalignant and more frequently recurring at a younger age. So those people are correctly being offered a colonoscopy. We would normally have done those at 2 years. I am comfortable about 3 years, given that polyp to cancer is usually 5 years, maybe more rapid in some of the high-risk patients. I'm reasonably comfortable about that one, and that's every 3 years. And number 5 is high-risk people, 10 or more adenomas, or if you've done a piecemeal removal of a large sessile polyp and you want to go back and look to make sure you've got it all or it hasn't recurred, and that's fine. So there's no problem with those. So you can see we're pretty comfy with a lot of the working party's recommendations. The one that I am concerned about, to remind you, we'll come back to, is that family history. Number 6 is the genetic scenario, the Lynch syndrome, familial polyposis, a genetic mutation, You can do them once every 12 months. We don't usually recommend that, but it might be that often, usually every couple of years. Depends on the number of polyps. And an unusual one, which we will rarely use, item 7, which is for some special situations here, and that's fine. And item 3228 is an unusual one, and it allows me the clinical judgment to determine that, in my estimation, this patient has a situation that warrants a colonoscopy, but doesn't actually fit any of the criteria that were mentioned in the earlier items. The interesting thing about this one is that that patient can only have one Medicare-funded colonoscopy utilising that item in his or her lifetime. Now, that may be fine, but given the fact that I've actually already encountered a few people who fitted that category, but didn't quite fit all the other criteria for conditions that weren't covered, and I've only done them once, but I have a feeling that people like that may have that situation now, and in 5 or 10 years, maybe in the same scenario. And that's one which is not as concerning as the family history, but certainly is something that we may need to look at in the future. And finally, if you actually remove a polyp, this is an additive item, not a concern. It's a multiple item, as is surgery, where you do 2 procedures and you're remunerated 50% of the second, and this is not a problem. That's fine. So there we go. So let's look at what the emphases of the new items are. You can co-claim the symptoms with removal of a polyp, no problem. Multiple item rules apply. We should be aiming seriously to ensure that in the federal versus state, the appropriate intervals between a positive FIT and a subsequently, hopefully, normal colonoscopy are as short as possible, so that for those who don't have a normal colonoscopy, actually have it done in a timely fashion so their pathology can be dealt with before it becomes more serious. If preparation is inadequate, we bill what is in fact an incomplete colonoscopy. That's fine. A definition of previous history is important, and that's been explained, and we understand from further discussions with government that that is the way in which we ascertain the criteria for their next procedure. Moderate risk due to family history, as I said, I'll come to, and the details on the exemption item we've discussed. I was reminded when all of this came out of the Utopia series previously shown on the ABC, which was the National Building Authority pseudo-authority, and if you haven't watched it, please do, as regard to the fun of bureaucracy. So the family history of bowel cancer was, as I said, one first-degree family member who got his or her bowel cancer, the proband, younger than 55. First of all, if Dad had a bowel cancer at 56, was it 56 that he was diagnosed, had the operation, started to get his symptoms, or given the 5 years from polyp to cancer might have been growing that polyp? And therefore, would 60 be reasonable, or did he have to develop his polyp at 50? And anyway, does Dad live in England and patient lives in Australia? And we're not sure, and Dad never told us, or I haven't seen Dad for 30 years, etc., etc. So a cut-off at 55 showing what is called a moderate risk is, quite frankly, with the rest of it, I think, being really well done by and large, This is ridiculous. And I happen to understand that most of the advisory committee looking at this felt, as I and others do, we think patients will be at risk with this, and we will be trying to push government to change this to offer the assessment more frequently. Because if you have a family member under 55 first degree, or 2 or more first degree family members with a high risk, you should be doing colonoscopies at younger and more frequent intervals and covered by Medicare. We think this is an important thing. So I'll move on from that, and there we go. We've discussed a little bit about retrospectivity versus prospectivity, because indeed my understanding from subsequent discussions with government preparing this slide is that the indications for further colonoscopies other than current symptoms, that's the 2 item, current symptoms which are covered prospectively will be from previous history and therefore are indications. And there is also a reasonable period between November and the very near future for us to change our patient recall systems, which have been honestly and hopefully effectively done. I mentioned a while ago that the recommendations of 2-yearly, 3-yearly, 4-yearly or 5-yearly colonoscopies for significant and reducing reasons were the way in which most of us had practiced, and I can tell you they yielded a 30%, approximately all of them, varied a little bit, a 30% chance of a further polyp less than a centimetre carrying a less than 1% risk of cancer. And that seemed reasonable because if theoretically a new polyp occurred the day after the colonoscopy and was left for 2 or 3 times the length of time for a further assessment, then the risk of cancer was higher. But still, as I've said, the recommendations, A, I hope you understand them a little better, and B, and that will help you in your decisions about referral, recommendations, and that you will push FIT with your patients. I hope that will be helpful. And then I've mentioned the get out of jail free, which is the item use of the 8. We must be careful not to do that. This is really for my colleagues rather than general practitioners. Do not overuse that item. It's wrong. It's there for a specific purpose. But there are other reasons for needing to do a colonoscopy other than lesions of the mucosa suspected, such as I've mentioned there. Are the patient's symptoms due to diverticulitis? Is there an ovarian cancer we're dealing with which might warrant assessment of the colon because there's a stricture created by the endometriosis? So there are other factors, but I think reasonably accepted by government. So we, the colorectal surgeons and gastroenterologists, need to develop new recall categories in keeping with the new guidelines. We have to be careful to document the rationale for recommendation in every patient's file carefully. This is part of the way we live now, not to abuse the symptom item, that's the 2 item, or to overuse the 8 item. And to use it, however, if your clinical judgment is, we're uncertain, but that's what we think we should do. Assume a reasonable grace period, which we're going through at the moment. I am sitting frequently and longitudinally reallocating all our old recall patients to a new program, and we need to have letters of explanation to our patients when we might change their recommended recall interval, and we interview them as appropriate. And it's up to all of us to note problems with the new system to be sure our patients' risk factors are not encumbered in any way, and that they still have good care and prevention. And if necessary, we'll talk to our local politicians about it. And thank you for your attention.